right, welcome everybody. We're just giving everyone another minute or two to join here. Looks like we've got participants continuing to join, so let's give it another minute. Okay, great. Looks like we still have a few joining, but in the interest of time, I think I will go ahead and tee it up to you. So Dr. Stephen Nathan, thank you so much for being here today and for your support of AUCVPR's virtual annual meeting. We are very excited to have Lung Biotech present today. So I will go ahead and pass it over to you and ask that everybody feel free to enter questions or items for discussion in the chat within the Passable platform. And once again, Dr. Nathan, thank you so much.
My pleasure, and thank you for the honor of allowing us to present here today. And the title of my talk, as you can see there, is COPD, Perfect Time to Uncover the Veil of PH, which is pulmonary hypertension. And I'm talking on behalf of the Perfect Clinical Trial, which is the perfect opportunity for all of you to be involved, being that you guys are the ones in the trenches seeing patients with COPD all the time. And I suspect that you have candidates who might qualify for this clinical trial. So I'm going to give you some background on pulmonary hypertension and where the study fits in and how to be aware of and be on the lookout for pulmonary hypertension. Just as a kind of a primer or refresher, I just want to go through the hemodynamics of the heart and what normal pressures are. So typically when we do a right heart catheterization or Swan-Ganz catheter, we measure the right atrial pressure anywhere from 1 to 5, the right ventricular pressure. The one that we focus on is the pulmonary artery pressure, and the systolic here is 15 to 34 to 12, or with a mean of 9 to 19. And then we measure a wedge pressure to rule out significant left-sided heart disease. These are normal pressures. So what defines pulmonary hypertension? The definition has changed pretty recently within the last 2 or 3 years. And it's defined by a mean pulmonary artery pressure of 20 millimeters or more. The only way you can verify this is with a right heart catheterization. And we talk about precapillary pulmonary hypertension if this is accompanied by a PVR, which is pulmonary vascular resistance, more than 3, with a wedge of less than 15 to rule out significant heart disease. This is a summation, a cartoon depiction of the World Health Organization classification of pulmonary hypertension. There are basically 5 groups. The group where most of the studies and all the drugs are approved are group 1, which we refer to as pulmonary arterial hypertension. So PAH is not the same as PH. PH encompasses all 5 groups. PAH refers to group 1, which is the idiopathic connective tissue disorders. PH due to heart disease, left-sided heart disease is group 2. This is what we're going to be focusing on, PH due to lung disease, specifically COPD, and I'll also mention interstitial lung disease. Group 4 is a somewhat uncommon condition, chronic thromboembolic pulmonary hypertension, and group 5 is various miscellaneous conditions. So why do patients with pulmonary hypertension, with COPD get pulmonary hypertension? And there are probably many factors involved. Certainly there's the role of comorbidities like OSA, heart disease, metabolic component from acidosis and hypoxemia. You can get vasoconstriction. You have destruction of the vascular bed, a reduced vascular bed, VQ mismatching. You have certain cytokines that are released during COPD that might affect the vasculature. We talk about vascular remodeling. There's also mechanical vascular compression. As you get hyperinflated lungs, it's compressing the normal lung units that are in close proximity. So mechanical compression, also due to air trapping and hyperinflation. And then certainly smoking by itself can cause vasoconstriction and pulmonary hypertension. This is a histogram distribution looking at 2 cohorts of patients, to the left COPD and to the right IPF. All of these patients had right heart catheterizations, just to show you the distribution of their PA pressure. So if you look at the COPD patients and we look at those with 20 and above, not a small group, of course, they have to have a PVR of more than 3 Wood units. But as you'll hear about the PERFECT study, we're looking for patients specifically with a PVR greater than 4. So we're trying to enrich the study by including patients who have more significant pulmonary hypertension, very similar to what we see in IPF. So the histogram distribution of the PA pressures in COPD is remarkably similar to what we see in idiopathic pulmonary fibrosis. And certainly there are some patients who have quite severe pulmonary hypertension within the COPD population. This is a summation of many different studies looking at the prevalence of pulmonary hypertension in the literature. And this is kind of all over the place, from anywhere from 1% to 90%. It depends how it was defined, and it depends how it was looked for. Some of these were echo studies alone. And I'll just focus you on the more severe patient population, because those are the ones we're going after with the perfect study. And it's anywhere from around 1 to perhaps 5% of COPD patients can have more severe pulmonary hypertension. pH in COPD, it's out there if you look for it. And this is a study that we did where we tapped into the UNOS database of all COPD patients listed for lung transplantation. And of course, this is a group of patients with more severe disease, just to show you the distribution above 20 and divided by PVR greater than 3 or less than 3. So it's important to take the PVR into account. And of course, the PVR is going to go up more. You're going to have more patients with greater than 3 Wood units, the higher the mean PA pressure is. But it seems like PVR is really kind of the driver of outcomes in many of these cases, as I'll show you later on. If we look at the general prevalence of COPD in the US, anywhere from 12 to I've seen as high as 14 plus million. And if we think about 1 to 5% that have MPAPs, mean PA pressures greater than 35, that's not a small group, 126,000 to 630,000. So these patients are out there if we look for them. There also appears to be this severe pH in COPD, or what we call this vascular phenotype, who have less severe airflow obstruction or more hypoxemic, maybe those typical old blue bloaters that we used to talk about. They have very low diffusing capacities, and they tend not to be hypercapnic, but more normocapnic or even hypocapnic. And these folks are very limited and require substantial supplemental oxygenation. This is a study that was done and published in Chest, 2005, so a while back, and they did a cluster analysis. They looked at clusters of these patients, and they looked at FEV1 versus MPAP. The first thing you'll note is that there's a very poor correlation. It's a scatter plot. So the mean pulmonary artery pressure doesn't correlate very well with the FEV1 because there are many other factors that go into the development of pulmonary hypertension. So here we have cluster 1, cluster 2, cluster 3, and cluster 4. The one of most interest to us are the ones with what we sometimes refer to as just disproportionate pulmonary hypertension. These folks here, cluster 4. And then if you look at what our criteria are for the perfect study, I'll come to this at the end of the talk, but they have to have a mean PA pressure, I believe, greater than 30, but with a PVR of 4 or more. So these patients are all potentially in the ballpark for potential enrollment in the perfect study. Does it matter if these patients have pulmonary hypertension? What are the effects on survival, functional status, quality of life, hospitalization, and does this have implications for comorbidities? And the answer to this is yes, 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 and one more yes. So let's look at some of that. And we've known about this for a while. If you go back to this paper, 1981, where were you in 1981? That was actually my last year of medical school. But here we have patients divided by MPAP as measured by right heart cath, less than 20 or greater than 20. And you can see that this does discriminate survival very nicely. So we've known about pulmonary hypertension as an issue in COPD patients for a long time now. The severity also matters, as you can see from this study published in 2005, that the more severe the pulmonary hypertension, the worse the outcomes. This is a more recent study just published very recently in the European Respiratory Journal, looking at patients divided by both the MPAP of 33 as well as a PVR of greater than or less than 5. And it certainly looks like it's the PVR that drives the worst outcome. So even these two groups over here, less than 33, greater than 33, both with PVRs greater than 5, this is what drives the worst outcome. So there is this very strong correlation between PVR and MPAP, but yet nonetheless, you have to look at the two in concert with one another. Another study, and this time the PA pressures are divided at 18, so slightly below what our definition of pulmonary hypertension, but very likely that many of these patients greater than 18 did have pulmonary hypertension. And these patients were more likely to be hospitalized. So these are the patients who keep coming in and out of the hospital. And sorry, I'm going backwards there. Also, patients who have acute exacerbations might be more predisposed to pulmonary hypertension. This was a very interesting study looking at the pulmonary artery size on CAT scan. Over here, we have a measurement of the pulmonary artery in relation to the aorta. If this ratio is greater than 1, in other words, if the PA is bigger than the aorta, that's a very strong indicator of pulmonary hypertension. And what they looked at was the PA to aorta ratio as a risk factor for acute exacerbations. And they showed it nicely over here. If you look, remember I said a ratio of more than 1 indicates pulmonary hypertension, and these patients were more predisposed to hospitalization. So another group of patients are patients who are in and out with acute exacerbations, and screening those patients and being aware that they might have pulmonary hypertension as a possible risk factor or association with acute exacerbations. This is just 4 CAT scans of 4 COPD patients looking at the different lung morphology. So you can, just an example, severe bullous disease over here, but the FEV1 is very well preserved at 64%. Here, the FEV1 is 44%. These lungs look more or less normal to me, but here you can see a very large PA. This is with contrast. Look at that, the PA measurement there versus the aorta. Clearly, the ratio is probably around 1.4. Another COPD patient, very low FEV1, 23%, but the parenchyma itself actually looks pretty normal. And here's someone with 13%. You can see a paucity of lung markings over here. But just to kind of drive home the point that you can have patients who have exactly the same FEV1, but their lung morphology might look quite different. I think most folks who deal with COPD are aware of the Bode index. If you focus on the right here, we can see how the FEV1 by itself discriminates survival. But to the top in panel A, you can see how the Bode index discriminates survival even more than just the FEV1 alone. As a reminder, what's the Bode constituted by? It's constituted by FEV1, walk distance, 6-minute walk, dyspnea scale, and body mass index. But there are 2 factors in here that are not captured by the FEV1, walk distance and dyspnea scale. And is this a clue that maybe these patients have pulmonary hypertension and that's why they walk less and get more short of breath? So that's what I mean by hiding in plain sight. These patients are there. They might manifest a little bit differently in terms of symptoms, oxygen needs, but if you look for it, you can find it. Another study looking at the DLCO, which is another good surrogate for pulmonary hypertension, and showing that a DL differentiates survival more than the FEV1, perhaps another indicator or the tip of the iceberg that many of these patients with low DLs in actual fact have pulmonary hypertension, which is driving their worst outcomes. So this summarizes all the things to be aware of. And I would say for the folks in the trenches, which are you guys doing rehab on these patients, these are the things to be on the lookout for to make one suspicious that there might be pulmonary hypertension. Shortness of breath that appears disproportionate to the patient's lung function. When we listen over the second heart sound, listen to the second heart sound in the second left intercostal space, we hear a loud P2 heart sound. So instead of da-da, 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 you hear da-da, da-da, da-da. I never thought I'd be saying da-da, da-da, da-da during a talk, but I just did. The lower the DL, the more likely it is that the patient has pulmonary hypertension. And then within the 6-minute walk, there are many clues. The less the patient walks, the more they desaturate, the more oxygen they need, and the lower their pulse rate recovery, the more likely it is they have pulmonary hypertension. For those of you not familiar with pulse rate recovery, that means their pulse rate 1 minute into recovery after the 6-minute walk. So if at 6 minutes their pulse is 120, and after 1 minute of rest it's 110, then the pulse rate recovery is 10. The lower the pulse rate recovery, the more likely it is that they deconditioned, have a cardiovascular limitation, or have pulmonary hypertension. We spoke about the PA size. These are our biomarkers for pulmonary hypertension. Echo is probably our best screen, but in COPD patients in particular, it's notoriously inaccurate because many of them are hyperinflated and the echocardiographer cannot get a good window. So don't rely on echo, especially in COPD patients, to rule in or rule out pulmonary hypertension. PH is never a diagnosis made by echo. We always need a right heart cath. So what we know is that pulmonary hypertension commonly complicates the course of COPD. It's associated with worse survival, reduced functional status, and possibly acute exacerbations. What we don't know is whether pulmonary hypertension is the driver of outcomes or maybe is a surrogate of other badness going on in the lungs. And we still talk about, even though we're not supposed to, about disproportionate pulmonary hypertension and what that might be. What we don't know, but shouldn't be too scared to ask, is should we treat the pulmonary hypertension of COPD? If we do, Does it impact functional status? Does it impact survival? And we always have to be leery about doing more harm than good. This is a summation of all the drugs that are out there approved for PAH, Group 1 pulmonary arterial hypertension. And the more drugs we have to play with in Group 1, the more enticing it becomes to take them to Group 3 and see if they work in patients with lung disease. The concept is simple here. Patients who have COPD and pulmonary hypertension, do they have a ventilatory limitation or do they have a pulmonary vascular limitation? We know they're short of breath, they have a breathing limitation, but if it's due to a pulmonary vascular limitation, can we do this by a pH drug and improve their pH so that their limitation is no longer their pulmonary hypertension, but becomes their ventilatory limitation? Another concept slide where we look at pH as a primary determinant of outcomes, but is there an inflection point where their pH gets so bad that that becomes the main driver of outcomes? Just a concept. I'm not going to go through all of this, don't worry. This is a summation of some of the trials, of which there are many out there, looking at some of these agents in COPD. A few of them have been randomized control studies, but for the most part, they've been pretty small. Some positive signals as depicted in green, but some negative signals as well. So we don't know for sure if treating the pH of COPD is helpful or not. And certainly there are no drugs approved to treat pH related to COPD. Another busy slide, but just to make the point that there have been 2 meta-analyses that have summarized the available literature, and both of them have suggested that treating COPD patients with a complicated pH, that there is benefit in doing this, but no definitive study as yet. This is a small study out of Italy looking, this was a randomized control study, 28 patients. And this was a positive study. Their primary endpoint was a pulmonary vascular resistance, but they introduced what I think is an important concept, and that is to look at the MPAP in relation to the FEV1. So for example, if the MPAP was greater than 35, you could enroll patients with FEV1s less than 30. But if your FEV1 was greater than 30, then you could get in with the MPAP of 30 plus. So the lower the FEV1, the higher the MPAP, because it's more likely then that the FEV1 is the limiting factor rather than the MPAP. Hopefully I didn't twist over my tongue trying to explain that concept. More recent data, this is from a European registry called the Compara registry, and they looked at patients who were responders to pH therapy and those who were non-responders. And a responder was regarded as someone who had an improvement in their functional class or an increase in their walk distance at 6 months of 30 meters or more. The implication was that if you responded to therapy, you lived longer. Of course, this is registry data, can't make too much of it. Is there some kind of selection bias to those who were responders? But nonetheless, there is a good basis and foundation that perhaps treating the right group of patients who have COPD with pH might bear fruit and might be a viable treatment option for these patients. And I think especially for the more severe patients who perhaps are well beyond the bronchodilators, we have all these triple therapies of bronchodilators, keep dilating the vessel, the bronchi, but there's just so much improvement you can get out of that, as I'm sure you're all aware and familiar with. Let's switch gears a little bit, and we're going to talk now about ILD, because this was a breakthrough and landmark study using inhaled treprostinil, the same agent now being developed and studied in COPD, in pulmonary hypertension due to interstitial lung disease. So I'd call kind of the sister disease to COPD. Under group 3, we have interstitial lung disease. This was published in the New England Journal of Medicine in January of this year, and I had the privilege of presenting this data at the ATS in 2020. This was a study design. It was the largest study in group 3 pulmonary hypertension, 163 patients in each arm. Everyone got randomized to either inhaled treprostinil or placebo 4 times a day. And the primary endpoint at 16 weeks was the 6-minute walk distance. This was a breakdown of the groups. You can see various forms of interstitial lung disease here. Most of them had an idiopathic interstitial pneumonia. That's where IPF sits, the most common of the ILDs. Some patients had combined pulmonary fibrosis and emphysema. CTD ILD is connective tissue disease, chronic hypersensitivity, etc. This was a fairly sick group of patients. 73%, 70% of them were on oxygen, and some of them were on antifibrotic therapy. So this is another group of patients you can be on the lookout for in your rehab programs. I know that our rehab program has a lot of ILD patients because we are an ILD center, and some of you might have few of these folks, but there is this as an option out there for your ILD patients now as well. So if you have an ILD patient who needs oxygen, there's probably a good chance that they have underlying pulmonary hypertension. And those same parameters I showed you for COPD apply to patients with interstitial lung disease as well. The primary endpoint was change in the 6-minute walk distance at 16 weeks. And we did hit on this primary endpoint with a placebo-corrected difference of around 31 meters. Most of this driven by improvement in the treatment arm versus deterioration in the placebo arm. So this was a positive study based on the primary endpoint, as well as some very important secondary endpoints, including time to clinical worsening, where inhaled treprostinil beat out placebo. 22.7% had an event versus 33% had an event. And you can see the breakdown of the various events that happened. This was a composite endpoint. The 4 components of the composite were either hospitalization due to cardiopulmonary indication, 11% versus close to 15%, decrease in the walk distance of 15% or more, 8% versus 16%. Mortality was equivalent. And then 2 patients in the inhaled treprostinil arm also got lung transplant. Nonetheless, this was clinically significant, statistically significant, and I would argue clinically significant as well. So we had all of our clinical parameters being positive and going in the right direction. But what was even cooler was to see our biomarker going in the same direction. That's our NT-proBNP or BNP. That tells us about right ventricular stress and strain. In the inhaled treprostinil arm, it went down, and in the placebo arm, it went up. And we know that the right ventricle drives outcomes in most forms of pulmonary hypertension. So we could see that this was of benefit to the right ventricle. This is what is known as a forest plot, looking at various subgroup analyses, and I'm not going to go through them all. Suffice it to say, all the point estimates are to the right of the line of unity. So there was no one group who did poorly, or no one group in particular that drove this outcome. The outcome was seen ubiquitously across these various subgroups. But one thing I will point out to you is this apparent dose response. If you look over here, those patients who are able to get up to the most breaths 4 times a day appear to have the best response. So this is something that we start off at 3 breaths 4 times a day, and then slowly try and titrate them up to 12 breaths 4 times a day. But I think this is important information going forward. If you can get the patients to the top range of the dose, they're more likely to have a positive benefit or a greater benefit. So on March the 31st of this year, the FDA approved inhaled treprostinil for pulmonary hypertension associated with ILD. And I truly believe that this is a paradigm shift in how we manage these ILD patients, that we have to have an increased awareness for pulmonary hypertension, be on the lookout for it more aggressively, because we now have a treatment option to offer these patients when they develop pulmonary hypertension. So here we have some unicorn bookends. I chose unicorns in particular because both of these conditions are not that rare. And certainly COPD PH is more common than ILD PH. Hello, my name is Increase study, and I'm perfect. So I want to introduce you to the perfect study of inhaled treprostinil in patients with COPD. This is it over here. It's a phase 3 adaptive study to evaluate the safety and efficacy of inhaled treprostinil in participants with PH due to COPD. Multi-center, randomized, double-blind, placebo-controlled, 30-week crossover study. So patients will get placebo or treatment at some stage. Initially, they might get placebo, then they'll have a washout period, and then they'll get treatment, and vice versa. But no one's going to know who's getting what at which stage of the study. And then everyone gets open label drug after completion of the study. The primary endpoint is once again change in the 6-minute walk distance at 12 weeks. I'm not going to run through all the secondary endpoints, but there are many different secondary endpoints that are important to the patients and important to the disease quality of life metrics. We have our NT-proBNP here as well. We're going to do actigraphy and look at moderate to vigorous physical activity. So this is really going to be a deep dive into this to see if inhaled treprostinil, if the same holds true in COPD PH as it did in PH-ILD. The criteria are shown over here. FEV1 has to be less than 80%, ratio FEV1 to FVC less than 70%. They have to have a saturation of 90% or more with or without supplemental oxygen. They can't be too debilitated, and these are the right heart cath parameters. A little bit higher than standard pulmonary hypertension. Their PVR needs to be 4 Wood units or more. Pulmonary artery, the wedge pressure needs to be less than 15, and to rule out heart disease, and the MPAP greater than 30. So once again, we're trying to enrich by getting at this more pulmonary vascular phenotype in the context of COPD. Main exclusion speak for themselves. PH due to other reasons. Alpha-1 patients are unfortunately excluded as well. Significant left-sided heart disease, or if they're on any kind of treatment already for the underlying PAH, or it should be for PH rather. So this is where I'll end off. The study's taking place throughout the US. All these dots represent sites around the country who are perfect clinical trial sites. Hopefully there's one close to you that you can communicate with, and you can get more information at clinicaltrials.gov. For those of you who have your cameras handy, you can take a picture of this and go to the website. But perhaps this is an easier website to remember, www.perfectclinicaltrial.com, and that will direct you to whatever you need to know with regards to this study. So once again, be on the lookout for pulmonary hypertension. I think folks in the pulmonary rehab programs are very well positioned to help us recruit for the study. I think it's an opportunity for us as a community to really make an impact beyond our traditional bronchodilators. This is offering treatment at another important aspect of the disease that's hiding below the surface. You guys out there are seeing these patients, not just a one-time visit, but they come in, they get their 36 sessions or 3 months, however long it is. You establish a rapport with the patients, you walk them, you can see how much oxygen they need, you can see the ones who desaturate more, and you get to know these patients. And I think especially coming from people who develop a rapport with the patients, if you can talk about the study and encourage your patients that perhaps they might be candidates for this, talk to the physicians who refer these patients about, hey, are you aware of this study? Maybe this patient is a candidate for the study. I think between all of us, and hopefully you guys can help a lot with all the rehab programs that are out there throughout the US. So I'll stop there, and I think we'll be happy to take any questions. Thank you all very much.
Dr. Nathan, we have one question. One person is interested knowing if this drug can be beneficial in emphysema patients with PH.
Yeah, I think that's why we're doing the study, absolutely. I think that's why the study is so important, is to come up with a definitive answer if inhaled treprostinil is a true and viable treatment option. If it is, I mean, we could potentially change the face in the treatment paradigm that currently exists for COPD and be able to offer our patients new hope, especially for those patients with more severe disease who are perhaps maxed out on their bronchodilators. So I think this is a great opportunity for us as a pulmonary community to come together, populate the study, and get the answer that we need. Any more questions?
Thank you so much, Dr. Nathan. Heidi and Victoria, were there any more questions in the chat that you wanted to bring forward?
I do not see any more questions in the chat.
No, neither did I.
All right, well, I want to thank everyone for attending once again, and enjoy the rest of the conference, and be on the lookout for more from Perfect, and hopefully we can complete the study. And I'm cautiously optimistic that we can have a positive study if we get to complete it, but we're going to need the community's help. And I think you guys, once again, are perfectly positioned to refer patients for enrollment in this study. Thank you all very much.
Thank you, Dr. Nathan.
Thank you so much, Dr. Nathan.
Sure thing.
And yes, you will certainly be hearing more you'll be hearing more from ACVPR about ways that we can help get some recruitment efforts going. Thank you so much, everyone, for
we would love that
today. And please, everyone enjoy the rest of the ASVPR virtual annual meeting. Take care.
Thank you all very much. Have a good meeting and rest of the day.
Thank you.
Okay, bye-bye now.